Hi, this is Rafael Martinez-Perez. Today I will show the surgical tenets of a complex tuberculum sellae meningioma resected through an endoscopic endonasal approach. This patient presented with progressive bilateral vision loss. Visual acuity was 2400 in the right eye with complete amaurosis on the left. MRI demonstrated an extra-axial contour-enhancing mass in the suprasellar region consistent with a tuberculum sellae meningioma. The lesion caused superior displacement of the anterior cerebral arteries and involvement of the left supraclinoid internal carotid artery, extending towards the inferolateral aspect of the left cavernous sinus. Both optic nerves and optic canals were involved more prominently on the left side. So we proceed with an endoscopic endonasal approach, including bilateral medial turbinectomies and posterior hemorrhoidectomies to achieve wide exposure of the S4A sinus. At this stage, it's critical to confirm anatomical landmarks. On the right side, we identify from anterior to posterior the planum sphenidale, tuberculum sellae, and clival recess, with the carotid arteries laterally. As previously emphasized in other videos, the middle opticocarotid recess is the key landmark for this approach. On the left side, given carotid involvement, attention is also directed to the medial clinic process. We proceed with progressive bony removal, starting at the superior aspect of the sella, followed by the limbus sphenidale and tuberculum sellae. Drilling is extended anteriorly over the planum, creating a trapezoidal window, typically at 2-3 centimeters from anterior to posterior of the planum. Exposure is often required to access the suprasellar component. The exposure is then extended laterally to skelettonize both carotid arteries. This circumferential exposure around the midoclinic process allowed the identification and mobilization of critical structure, including this midoclinic process, which in this case is prominent, and removed from anterior to posterior to expand the surgical corridor and the tumor acts involved in the cavernous sinus. After removing the middle wall of the middle opticocarotid recess, hemostasis is achieved with SurgiFlow. We then proceed on the right side, removing the middle wall of the optic canal and its proximal third, along with the corresponding middle opticocarotid recess. There is no cavernous sinus invasion on the right, so removal of the middle clinic process is not required. Similar decompression of the optic canal is performed on the left side. At this point, we have a wide bony exposure and full visualization of the dura. We begin by coagulating the dura above and below the intercavernous sinus, allowing us to open both the sellar and suprasellar compartments. The intercavernous sinus is coagulated and divided to minimize bleeding during the diaphragm opening. Using a number 1 dissector, we access the superior aspect of the tumor. Cotonoid patty is placed to protect the optic apparatus and create a safe dissection plane. Side cutter aspirator is used for its low profile to debug the tumor. After reducing the tumor volume, we use an Angelina number 1 to continue dissection of the lateral margin of the tumor and separate the tumor from the right optic nerve. As we proceed downward, we divide the dural attachment from the diaphragm with internal bulkhead and gentle elevation of the tumor and separation from the key structure that becomes visible, including the pituitary stalk and the basilar artery. Using a number 4 Angelina dissector, we continue towards the left side along the inferior aspect of the tumor. The tumor is adherent to the left internal carotid artery, so a thin margin is intentionally left to avoid injury to critical branches and perforators. We proceed with sharp dissection to remove the central tumor bulk, particularly in the portion compressing the midline and right side. Contact traction with cotonoids is used to protect perforators, including the superior epiphyseal arteries and perforators from the basilar artery. We control suction and continue dissection. Tumor posterior capsule. With controlled suction and continued dissection, the tumor posterior to the internal carotid artery is mobilized, rotated, and finally removed. The carotid artery defines the lateral limit of the corridor, and safe dissection requires maintaining an appropriate distance from these structures. At this stage, the sutural space is clearly visualized, including the pituitary stalk and surrounding vascular anatomy. Intraoperative ultrasound is used to confirm the location of the internal carotid artery. The distal dural ring serves as an important key landmark. It is safe to incise medially to the carotid at this level to access the tumor behind the supraclinoid segment. We then carefully dissect the tumor from the optic nerve, which is often encased by the arachnoid in this case. The distal ICA, anterior cerebral artery complex, and final tumor portion are identified and resected in a controlled fashion. At the end of the resection, we confirm complete tumor removal and preservation of all critical neurovascular structures. 30 degrees endoscope is used to inspect the cavity and ensure no residual tumor remains. All perforators are preserved. Reconstruction is performed using a multi-layer technique, including inlay dural substitute, fascia lata, and a vascularized nasoseptal flap. MRI shows gross total resection. Postoperatively, the patient did well with significant improvement in vision on the right side. The left eye remained amaurotic, consistent with a chronic deficit. This is Rafael Martinez-Perez. Thanks for watching and welcome to RMP Scalbase.